Andrew Wang, it is your turn for public comment.
Thank you so much for having me. I'm very grateful that I could be here. My name is Andrew Wang, and I just want to express my sincerest appreciation for all of you here today, especially those physicians working in infectious diseases, working in public health. I know it's been a very exhausting last 4 years, but nonetheless, we need to continue to consider and remember that COVID-19 remains a pandemic here in the United States and across the country. Just providing a little background, I have no financial disclosures today. I have a PhD in public health from Northwestern University and a master's of public health from Columbia University as well. I previously worked in occupational medicine, protecting healthcare workers for a large academic institution in Philadelphia. Currently, I work in a federally qualified healthcare center serving over 70 to 80,000 individuals living in the west side of Chicago. Majority of those are Black, identified as Black, African-American, Hispanic, Latino, Latinx. And today, I would like to express my sincere appreciation for this chance to comment on this current proposal. Thank you, Dr. Lin, for your time today to let me speak today. I just want to express that the COVID pandemic has not ended, that healthcare workers need to be protected, ensure that they need to be both protected and patients need to be protected. COVID-19 is an airborne disease. It is transmitted through aerosols, and that is why N95s are more superior than surgical masks. When I previously worked in occupational medicine, we strongly recommend and urge our healthcare workers to don N95 masks whenever they care for patients who have an aerosol situation. Therefore, this is why N95s are necessary. N95s are not that expensive. They are not a huge burden for healthcare systems, as I previously had to handle and manage the financial situation for my healthcare system. Second, the CDC, HICPAC should include more expertise from aerosol scientists. Infectious disease scientists and physicians are really important, but we need to include aerosol scientists and occupational hygienists to be a part of this discussion. We already seen today that this review that was demonstrated in the slide deck regarding masks is not an appropriate review. I've done systematic reviews before, and this review does not prove or demonstrate that N95 masks are not effective. We compare this to example of parachutes. People do not jump out of planes, and if people jump out of planes with parachutes, it's effective. If some parachutes don't work, we don't necessarily take away parachutes. We add another layer of parachutes. We provide a second backup parachute for those who jump out of planes. And my last comment here is that patients who are admitted for procedures need to be tested for COVID-19. The prevalence continues to remain high across the country. We see wastewater remain high as well, and that patients should be tested for COVID-19. And if they are tested positive, they should be kept in isolation and placed in negative pressure rooms. And so I just want to say thank you so much for your time today. Continue to be transparent, allow the public to be a part of this conversation. Thank you so much.
Jane Thompson, it is your turn for public comment.
Hi, my name is Jane Thomason. I am a certified industrial hygienist with National Nurses United, which is the largest labor union and professional association for registered nurses in the United States. NNU stands with more than 24 other organizations to urge HICPAC and the CDC to ensure the following elements are upheld in any updates to the 2007 isolation precautions guidance. Number 1, fully recognize aerosol transmission of SARS-CoV-2 and other respiratory pathogens. HICPAC and the CDC should ensure that updated guidance includes the use of multiple control measures that have been shown to effectively prevent transmission of respiratory pathogens, including SARS-CoV-2 and others, including ventilation to remove aerosolized viral particles and other pathogens, including the use of negative pressure isolation and other engineering controls, respiratory and eye protection for healthcare workers, providing care to patients with suspected or confirmed respiratory infections, and safe staffing is essential to effective infection control and prevention. Updated CDC HICPAC guidance must recognize this and must not make allowances for healthcare employers to circumvent measures necessary to protect worker and patient health due to staffing concerns. 2, CDC and HICPAC should maintain and strengthen respiratory and other protections for healthcare workers caring for patients with suspected or confirmed respiratory infections. N95 respirators represent the minimum level of respiratory protection available and are essential to protecting healthcare workers from respiratory infections. HICPAC and CDC should clearly and explicitly incorporate elastomeric and powered air purifying respirators or PAPRs into any updated guidance on healthcare infection control. PAPRs and elastomeric respirators can provide a higher level and more reliable protection than N95s, be more comfortable to wear, and more cost-effective for employers to implement. 3, the CDC must be clear and explicit on the precautions that are needed in situations where infectious pathogens are or may be present in healthcare settings. Don't adopt a crisis standards approach. 4, CDC and HICPAC should engage with direct care healthcare workers, their unions, patients, and community members to provide them with the ability to review and provide essential input into guidance updates. We are concerned about the lack of transparency in your process to update the CDC's 2007 Isolation Precautions Guidance document. Changes to this guidance will impact healthcare workers, patients, and communities in every state, but you have no clear mechanism to garner input from those healthcare workers, their unions, or patients and community members before the updates are finalized. For example, you voted before hearing public comment in this meeting today. Other organizations in support of these points have or are planning to comment for themselves and also include the International Union UAW, the Occupational Health and Safety section of the American Public Health Association, National Council for Occupational Safety and Health, the National Federation of Federal Employees, the National Union of Healthcare Workers, UFCW Local 222, Civil Service Employees Association Local 1000 AFSCME, Pandemic Equity Initiative, Long COVID Justice, and others. Thank you.
Thank you for your comment, Jane Thomason. Brianna, we can go to the next person.
Irma L. Westmoreland, it is your turn for public comment.
My name is Irma Westmoreland. I'm a registered nurse and vice president for National Nurses United, the largest labor union and professional association for registered nurses in the United States. As you update the isolation precautions guidance, it is important for you to incorporate input from direct care nurses and members of my union. I strongly urge HICPAC and the CDC to maintain strong and clear guidance on the precautions necessary to protect healthcare workers and our patients from infectious diseases, and to refrain from flexibility that ignores science. Healthcare employers say they need flexibility to respond to the healthcare staffing crisis, but our experiences as direct care nurses during the COVID pandemic have underlined the dangers of too much flexibility in infection control. Early in the pandemic, many of our employers removed protections for nurses and other healthcare workers caring for COVID patients. Nurses saw our employers restrict our access to N95 respirators and then give us simple surgical masks, even when we were caring for known COVID patients. They implemented dangerous, unproven decontamination practices, even while having a supply of new N95s in storage. Nurses confronted our employers about these unsafe practices, but our employers responded by saying they were following CDC guidance. CDC's crisis and contingency standards for COVID allowed our employers to race to the lowest level of protection, even when they could and should have done better. This led to many nurses becoming infected with COVID. By NNU's count, based on publicly available data, at least 5,700 healthcare workers have died from COVID, including at least 499 registered nurses, which is most likely severely undercounted. NNU's most recent nationwide survey found that many nurses are experiencing long COVID, which can disrupt our ability to work. It is because of these unsafe conditions created by our employers that nurses are now leaving the bedside in high numbers. Nurses are no longer able or willing to risk their patient's safety. The flexibility that our employers have enjoyed during the pandemic is significantly contributing to the staffing crisis. If HICPAC incorporates a similar approach into the isolation precautions guidance, it will have disastrous impacts on patients and nurse safety and will only worsen the staffing crisis. Strong protections from infectious diseases are essential to retaining nurses at the bedside. Please ensure updated guidance is clear and explicit on necessary precautions to protect us and our patients. Thank you.
Kaitlin Sundling, it is your turn for public comment.
Hello, I'm Kaitlin Sundling, an MD PhD physician scientist, pathologist, and assistant professor in Madison, Wisconsin. I'm a volunteer with the People's CDC. I have not been able to safely work in a hospital environment due to the loss of universal masking in non-patient care areas over a year ago. Now, patient care masking has also been dropped. I have multiple high-risk and immunocompromised family members, and they are not able to safely access care. Members of our community, including high-risk and disabled folks, find that they must beg their healthcare providers to mask. And even then, they're moving through crowded waiting areas and other shared spaces with no masking in order to get their necessary care. Airborne is airborne. There is no physical basis for variable distances of airborne transmission for different pathogens. COVID is airborne and can be transmitted by patients and healthcare workers who are asymptomatic. Healthcare facilities must require universal masking, ideally with N95 or better respirators for everyone in these settings. The proposal for 3 different levels of air precautions is inappropriate and dangerous. It's shocking to suggest that we need more studies to know whether N95 respirators are effective against an airborne pathogen. The science of N95 respirators is well established and based on physical properties, engineered filter materials, and our scientific understanding of how airborne transmission works, not clinical trials. N95 respirators have a great advantage in providing both respiratory protection to the wearer, as well as providing excellent source control. Fit testing should be provided to all workers in healthcare settings. We do not need to put patients and workers at risk in order to gather more data. In many healthcare settings, we've been doing universal masking for 3 years, and we just need to continue doing it. This is something that should have been part of basic infection control prior to the pandemic. Now that we understand we can reduce the risk of transmission of infectious diseases within healthcare settings through this measure, we need to add it to our arsenal. We need to add routine universal masking to our routine standard precautions. Now is the time to provide education for all healthcare workers so that everyone knows why and how to protect themselves from COVID and other airborne pathogens. Many healthcare workers do not understand how to protect themselves, or that repeated COVID infection poses increased risks of organ system damage and long COVID. We must not allow crisis standards to become the new lower routine standards of care that put patients and workers at risk. We at the People's CDC, as healthcare workers, patients, and others who are dedicated to improving public health, need your help. We need the CDC's HICPAC committee to help us implement universal masking and other protections to build safer healthcare for all of us. Thank you.
Thank you for your comment, Caitlin Sundling. Next one.
Kevin Kavanagh, it is your turn for public comment.
Kevin Kavanagh from Health. We would like to compliment the CDC on addressing aerosol spread of respiratory pathogens. However, we have some concerns regarding the proposed recommendations. Aerosolized particles have a continuum of sizes and can be both solids and liquids. Smaller particles arise deeper in the respiratory tract and are more likely to contain culturable viral particles. The National Academy of Sciences have found that aerosolization can occur with particle sizes up to 100 microns. The recent Cochrane review on masking focused attention on the quality of randomized controlled trials regarding mask effectiveness. Trials comparing the effectiveness of masks were plagued with poor compliance and intermittent usage. Masking trials cannot ethically be optimally designed and should not be used to undermine decades of occupational research. We have a number of concerns with the interim guidance for healthcare staff and patient safety during the COVID-19 pandemic. Cloth masks and surgical masks should not be advocated for the prevention of spread of respiratory pathogens. These are suboptimal for healthcare personnel and for use in the community. Current recommendations regarding limiting the number of persons in waiting rooms are vague and not specific. Visitors of patients with COVID-19 should not be allowed into other areas of the facility and need to wear full PPE and N95 masks. COVID-19 patients must have, not ideally have, a dedicated bathroom. They should also have a separately ventilated room which utilizes portable HEPA filters plus upper room UVC lighting. COVID-19 nursing home patients must be placed in single rooms or cohorted. They should not remain in current location if this exposes other residents. Healthcare-associated SARS-CoV-2 is an unreliable metric to determine when to use respirators, since the definition of hospital onset is flawed and will rarely be met. Facilities cannot use the levels of community transmission for guidance, since the data is no longer collected. We recommend expanding surveillance and leveraging EMR to identify cases. Facility-wide masking should be universally used in all hospitals and healthcare settings at all times. COVID-19 is endemic and at an unacceptable level, plus immunocompromised individuals frequent these settings. Even exposure of one susceptible individual is unacceptable. N95 masks or comparable masks must be used by all. ASHRAE is proposing equivalent air exchanges of 60 liters per second per person in healthcare waiting areas and 90 in healthcare patient rooms. The CDC needs to provide clear and specific recommendations for indoor ventilation, filtration, and UVC utilization. Thank you.
Thank you for your comment, Cousin Kavanagh. Next.
Deborah Gold, it is your turn for public comment.
Hi, can you hear me? My name is Deborah Gold, and I'm a certified industrial hygienist, and I'm working for Cal OSHA as a retired annuitant. I thank you for the opportunity to provide comments. I also refer you to the May 31st letter from Cal OSHA Deputy Chief Eric Berg for further elaboration. It will be helpful to update and revise the 2007 guideline to learn from the almost 2 decades of research and experience regarding the behavior of infectious aerosols and occupational exposures to illnesses, including 2009 H1N1, avian influenza, occupational Ebola, and COVID-19, and to make clear and protective recommendations. We agree that the distinction between droplet and airborne transmission in the 2007 guideline often leaves out inhalation route of infectious aerosols in the near and medium field. California's experience with COVID-19, for example, in prisons, nursing homes, and hospitals, demonstrates that many aerosols can be disseminated through shared airspaces over various distances. The revised guidelines should address appropriate and feasible isolation, including airborne infection isolation rooms, donning and doffing procedures for PPE, and sufficient and directional ventilation. The evidence review team yesterday released slides listing the studies upon which it has relied in determining that surgical masks and N95 respirators provide equivalent protection for most respiratory illness. Both the conclusion and the evidence cited are problematic. I have not yet had a chance to review all the cited studies, but I am aware that at least one of these studies, which found no difference for laboratory confirmed infection, did find differences in other outcome. The Loeb 2009 study found statistically significant higher incidence of febrile illness in the surgical mask group and a difference at p equals 0.06 of influenza-like illness. Also, several studies that are cited did not include assessment of effective respirator use, including observation of whether respirators were worn consistently, whether respirator users were trained and fit tested, and whether the effectiveness of the filtering facepiece respirators was reduced due to redonning. Some studies, such as those by Raina McIntyre, did find greater protection with the use of respirators. Limiting the outcome to laboratory-confirmed infection biases the conclusions to the null, as do most of the factors mentioned by the work group. Finally, the finding of no difference lacks scientific plausibility because research by the National Institute for Occupational Safety and Health, NIOSH, and other experts provide strong evidence that respirators, when used effectively, provide greater protection against the inhalation of aerosols. It also doesn't make sense to recommend respirators for a disease when it's classified as a pandemic and then drop it to mask when it's no longer considered a pandemic. The evidence review team should consult with the NIOSH NPPTL on respiratory protection. OSHA requires that in the workplace, respiratory protection be approved by NIOSH. Strong public health recommendations are essential for public health planning. At all levels, government and private organizations were unprepared for a pathogen that was as transmissible and virulent as SARS-CoV-2. HICPAC CDC needs to broaden this process and include healthcare worker unions, safety and health agencies, professionals, and scientists. Thank you.
Thank you for your comment, Deborah Gold. You can move on to the next one.
Jester Jersey, it is your turn for public comment.
Okay, my name is Jester Jersey. Good afternoon to HICPAC. Thank you. I want to mention that I have no pharmaceutical conflicts to disclose. Thank you for allowing me to address the committee. I'm a vaccine advocate, and I've worked with the fraternal service organization Kiwanis International, as well as UNICEF on the Eliminate Project, a tetanus vaccine campaign that significantly reduced the global incidence of tetanus from 2010 to 2020. I currently volunteer with Vaccinate Your Family and Voices for Vaccines, two great organizations that promote vaccine safety, support vaccine policy, and the well-being of all Americans from vaccine-preventable diseases. Today, I want to speak about my advocacy efforts. Immunizations are important. Last month, I addressed the FDA to support the new Pfizer vaccine, Abrysvo, and suggested strategies to limit the spread of RSV and other vaccine-preventable diseases. However, just as important are preventive measures for health personnel like those being discussed today, like gloves, masking, and other strategies. As we continue recovering from the COVID pandemic, more investment is needed towards prevention. You never know when an event arises that requires preventive measures to be taken. An example of this are the Canadian wildfires affecting air quality in many U.S. cities, like New York City. Masking has now returned to the national radar. However, unlike smoke from fires, contagious pathogens circulate silently and invisibly. We don't always have the luxury of national news coverage to inform a prompt preventative response. At this time, we have an opportunity to lessen the burden of RSV on the health field. However, recent low vaccination rates for the flu and COVID boosters are concerning as we prepare for this year's colder season. I think there's room for improvement for all of us engaged in preventative work. Therefore, I have two suggestions to make to the Healthcare Infection Control Practices Advisory Committee that you can pass on to your colleagues at the CDC, HHS, and other health leaders of President Joe Biden's administration. First, public prevention implementation is hard. Efforts can be easier by working with trusted messengers, such as community-based organizations that have vaccine advocacy experience, as Surgeon General Vivek Murthy has suggested early on for COVID. Second, continue to ensure accessibility of vaccines, like Section 317 of the Public Health Service Act does. This ensures vaccines are available for providers to give to those who need them, and to help Americans catch up on missed routine vaccinations. Together, these two suggestions can prevent strains on the national health system, including health personnel, and save lives in the process. Thank you for your time and consideration, and for the work that you do to protect healthcare personnel who in turn are helping protect all Americans. Thank you.
Recorded in our minutes. Thank you. You can move on to the next public comment.
Shimi Sharief, it is your turn for public comment.
So my name is Shimi Sharief. I'm a physician
You're
and
very clear.
Okay, perfect. Thank you. I'm a physician and public health practitioner. Commenting in reference to the presentation by the IP work group today, I do appreciate the discussion around protective environment and considerations for source control also. I'm speaking in partnership with NNU, National Nurses United, regarding the need for infection prevention of SARS-CoV-2 and other infectious agents with known aerosol transmission in healthcare settings to keep patients and healthcare providers safe from infection. Personally, I left my urgent care practice in early 2020 at the height of the COVID-19 pandemic, where I practiced part-time due to the unavailability and inconsistency of PPE recommendations and application in my particular setting in January 2020. The situation improved dramatically over the pandemic, enough for me to return to clinical practice in 2021 to 2022. The revision of transmission guidance to by air and by touch modalities is an improvement from the previously faulty dichotomy of exclusively droplet or airborne, which we grappled with as I worked at state governmental public health for 18 months at the height of the pandemic. SARS-CoV-2, unlike other pathogens, continues to have high rates of airborne spread and asymptomatic transmission. The studies on masking presented today comparing N95 to surgical masks in healthcare settings have been ripe with confounding and lack of consistency of use, enforcement, and community exposures at the time of the studies were conducted. But the physics of respirators argues for the effectiveness of N95s over surgical masks by definition for prevention of aerosolized infection. The ASTM guideline for face masks, moreover, is designed for a lower level of protection to the wearer and for source control, especially with the models available in healthcare settings, which do not guarantee a closed fit against the wearer's space. We are also at a time with COVID-19 where vaccines are not uniformly effective for infection or for long-term disability for most, let alone for immunocompromised people, and the availability of effective treatment and vaccines experiencing a huge gap with the loss of monoclonal antibodies, Evusheld, and outpatient remdesivir treatment. NNU reflects the needs of healthcare workers, including myself, in asking for the following, which includes to fully recognize aerosol transmission of SARS-CoV-2 and other respiratory pathogens, and the need for multiple infection control measures, including ventilation and PPE. The loss of several pandemic-era data gathering tools, such as pre-symptomatic and asymptomatic testing in healthcare, also means that we should assume periods of moderate to high transmission healthcare settings at all times, given the unique circumstances of combining infected patients with vulnerable patients in the same setting, and consider maximal approaches to PPE instead of a crisis care guidance and baseline required for healthcare employers to implement. We need to maintain and strengthen respiratory protection, other protections for healthcare workers, including the use of elastomeric and powered air purifying respirators into recommendations, which can be more comfortable for extended periods of wear, and also address concerns around skin breakdown, fatigue, breathing difficulty, and others. Thank you so much.
Move on to our next.
Dr. Kathleen Fagan, it is your turn for public comment.
Thank you for the opportunity to speak today. My name is Dr. Kathleen Fagan. I am a physician, board certified in occupational and environmental medicine. I'm also board president of the Association of Occupational and Environmental Clinics, a network of some 50 clinics across the US and Canada, whose chief goal is to prevent work and environmentally related injuries and illnesses. Many thousands of healthcare workers are treated in our member clinics. We rely on CDC's 2007 isolation precautions as the authoritative source on infection control to protect healthcare workers. We are greatly appreciative of your committee's efforts to update this guidance. The COVID pandemic has highlighted the vulnerability of healthcare workers. The Bureau of Labor Statistics reported that in 2020, the healthcare and social service industry was the only industry to experience an increase in work-related injuries and illnesses, a whopping 40% increase from the year before. 288,000 illness cases with days away from work were due to viral illnesses, primarily COVID. The CDC estimated that 1,496 U.S. healthcare workers died of COVID as of October 21. Other estimates are even higher at 3,600 deaths. We have failed healthcare workers. We know how to prevent exposure to airborne infectious diseases. Ventilation, effective PPE, and administrative controls, including sick leave and safe staffing, should have prevented these illnesses and deaths. N95 filtering face piece respirators, elastomeric respirators, and PAPRs should be a requirement for healthcare workers with airborne infectious disease exposure. All respirators should be fit tested per OSHA's respiratory protection standard. Studies show that the use and disinfection of elastomerics and PAPRs are feasible in healthcare settings. During your process, we strongly encourage you to obtain input from researchers, from healthcare workers, and from occupational health professionals, organizations, and agencies, including NIOSH, OSHA, and ACGIH. Healthcare workers' exposure to aerosol transmission of COVID and other airborne infectious diseases is only likely to increase. And as others have already said, our approach to protecting healthcare workers should be proactive and precautionary rather than reactive and crisis-driven. We owe it to our healthcare workers who are on the front lines caring for all of us. Thank you.
Thank you. Thank you. We can go to the next comment. Thank you, Dr. Kathleen Fagan.
Yaneer Bar-Yam, it is your turn for public comment.
Can you hear me?
Yes.
Thank you. My name is Yaneer Bar-Yam. I am professor and president of the New England Complex Systems Institute and a co-founder of the World Health Network. I have 6 statements to make. 1, the evidence review of N95 respirators compared with surgical masks cited today is incorrect because it is based upon incorrect mathematical assumptions. Even though the studies admit limitations, the mathematical expressions used to evaluate uncertainty intervals is incorrect, both in their means, the results are biased toward null results, and in their range, resulting in smaller ranges than is consistent with the study data. Again, while the limitations of the RCTs are often acknowledged, the mathematics of those studies and of the meta-analyses is not corrected to account for those limitations, and thus the study conclusions are based upon the wrong analysis. The evidence review also chose studies that are subject to those errors, omitting many scientific studies whose results indicate that N95s are much better than surgical masks. We have previously published one relevant study on mask study assumptions with a title starting Unmasking the Mask Studies, and we'll submit a second study shortly, which we can provide the panel. 2, While invalid, the dismissal of the increased effectiveness of N95s by those studies does not apply to elastomeric masks or PAPRs, just as for many other measures, scientifically validated causal transmission mechanisms demonstrate their effectiveness. Thus, higher levels of protection from transmission are available and can and should be used in practice and adopted in policies. 3, where are the studies measuring impact of provider N95 respirators on patients? Absent. Also, the adverse effects. Current UK reports say over 1/4 of infected patients were infected in the healthcare setting. Their death rates are also much higher. 4, the isolation precaution guideline workgroup materials do not directly mention asymptomatic transmission and should. 5, it should be a given that protecting individuals who are vulnerable to consequences of COVID infection should be a top priority in healthcare settings whose responsibility is making people well, not sick. 6, everyone is vulnerable to organ damage from COVID. This includes, but is not limited to, long COVID symptoms. This should be mentioned. Indeed, it should be emphasized in your statements and referred to in your policy recommendations. Thank you.
Thank you, Yaneer Barham. Brianna Holiday, can you go to the next one?
Barbara Materna, it is your turn for public comment.
Thank you. Can you hear me?
Yes.
We can hear you clearly.
I'm Barbara Materna, a certified industrial hygienist, and I'm retired from the position as chief of the occupational health branch in the California Department of Public Health. So my comments are not official comments from CDPH. First, I fully support updating the transmission-based precautions guidance. The current guidance's distinction between droplet and airborne transmission of respiratory pathogens must be replaced with a new framework supported by the substantial science and experience accumulated since 2007. Second, the workgroup's process must be made more transparent to the public with prompt online posting of meeting minutes and presentations. Early input is needed from the best experts in aerosol science, respiratory protection, and occupational health, and all important stakeholders, including healthcare worker unions, NIOSH, in particular its National Personal Protective Technology Lab, federal OSHA, and state OSHA plans. Third, the workgroup's categorization scheme for airborne pathogens must be reevaluated and replaced with a more justifiable approach. I would like more clarity on the basis for assigning pathogens to the 3 categories, but I don't see how the proposal reflects the evidence for aerosol transport within indoor spaces over medium distances beyond 6 feet. I'm very concerned that medical or surgical masks are the recommended protection for Category 1 pathogens, with seasonal influenza and coronavirus listed as examples. This approach acknowledges these viruses are transmitted by air, but would not effectively prevent worker exposure. Surgical masks are simply not designed to seal to the face and prevent inhalation exposure, nor are they certified for this purpose. Also, the proposal does not address higher risk aerosol generating procedures. Fourth, it's essential to maintain effective OSHA compliant respiratory protection programs in healthcare workplaces. Updated guidance should not allow for a watered-down approach to respiratory protection, such as relying on surgical masks or respirators that lack NIOSH certification. Fifth, we must improve emergency preparedness in our healthcare system. The COVID pandemic highlighted the need to assume inhalation transmission of emerging novel pathogens and protect healthcare workers accordingly with multiple control measures. Finally, we need to maintain worker protections for SARS-CoV-2. Long COVID poses an ongoing risk, and healthcare workers are already in short supply. Nothing less than a fit-tested N95 or better respirator is adequate protection. Thank you for your attention.
Nathanael Nerode, it is your turn for public comment.
Hello, can you hear me? Can you hear me?
Yes.
You are clear.
This is Nathanael Nerode. I'm affiliated with several organizations, but not speaking on behalf of any of them. In December of 2021, my partner, who is immunocompromised, went to a doctor's office for a routine gynecological exam and was infected with COVID by doctors wearing loose surgical masks. After recovering from this, in March, she went to another office for the same problem and was infected with COVID again by doctors wearing loose surgical masks. This is because surgical masks are not sufficient for prevention of aerosol transmission. It is essential that N95 or better respirators be used at all times. The standard precautions currently listed are insufficient and must be updated to require them under all circumstances. In both of the situations where my partner got infected, there were no suspected cases in the office. It makes no sense to go, well, there are no suspected cases, so we won't wash our hands. It makes no sense to go, there are no suspected cases, so we won't take aerosol precautions. I have to add that the evidence review was not fit for purpose. In addition to the comments made by previous people, this omits the highest quality studies, which are available at the Addenbrooke Air Disinfection Study. You should read them. And it includes studies by Loeb. Loeb 2022 has been debunked multiple times, and I have emailed the debunkings to you. And in addition, Loeb failed to disclose a conflict of interest. Loeb was personally responsible for preventing Canadian nurses from getting access to N95 masks, which may well have injured and killed them. He did not disclose this conflict of interest. This makes all of his work suspect. In addition, many of these studies listed there have, including Loeb 2022, contained protocols that assumed the droplet dynamic, which is now discredited and known to be false. So I would like to thank you again for recognizing the nature of aerosol transmission as understood by physicists and aerosol scientists, the scientific consensus. But I would like to say that you need to understand the implications of that and provide aerosol precautions as part of standard precautions for all healthcare facilities. Until then, we will continue to have the extremely high healthcare required infection rate, which we currently have. About a third of the cases of COVID in hospital in Britain have been caught in hospital for the last 12 months, and it is similar in the US. Please update the standard precautions. Thank you.
Mark Nicos, it is your turn for public comment.
Good afternoon. My name is Mark Nicos. I am an emeritus adjunct professor in the School of Public Health, University of California, Berkeley. I have brief comments on several related topics. First, the particle sizes in an aerosol emitted from the respiratory tract range from less than 1 micron to over 1,000 microns. Large particles may not travel far, but particles 5 microns and smaller easily disperse throughout room air and will travel outside the room if negative pressure isolation is not maintained. That fewer secondary infections at a distance from, rather than close to, an infectious person would not involve the ability of particles to travel in air. Rather, the difference would likely involve issues of infectious dose and the decreasing concentration in air as infectious particles move away from the source. Second, for any respiratory tract infection transmissible by inhalation, which includes seasonal influenza, such patients should be housed in negative pressure rooms. This is especially important for pandemic-type pathogens causing high morbidity and mortality, like COVID-19 virus. Third, healthcare workers who attend patients with a respiratory tract infection transmissible by inhalation need to be provided at a minimum with N95 filtering facepiece respirators. For pandemic-type pathogens causing high morbidity and mortality, a powered air purifying respirator with high-efficiency filters is preferred. Surgical masks and medical masks are not sufficient, nor are barrier face coverings. Fourth, some HICPAC members believe a surgical mask is just as protective as an N95 filtering facepiece, and they cite studies purporting to show no difference. When establishing disease causation by a chemical, I'm sure everyone ascribes to the Bradford-Hill criterion of the biological plausibility of causation. The analogous criterion here is physical plausibility. That is, via a lot of laboratory testing, it is well established that surgical masks permit more filter penetration and more facial leakage than do N95s. Therefore, how can a surgical mask perform just as well as an N95 in preventing an infection transmitted by inhaling infectious particles? That result is physically implausible and indicates one or more errors in how the study was conducted. The errors likely include accurately determining exposure potential and compliance with using the N95 respirator. Here is my experience as part of a study that evaluated adherence to CDC TB control guidelines in 3 hospitals. We evaluated compliance with respirator use by sitting down the hallway from TB patient rooms and directly observing the staff as they entered the rooms. Failure to wear a respirator as required was not uncommon. I doubt that self-administered questionnaires would have indicated the same degree of noncompliance. Thank you.
MK Fletcher, it is now your turn for public comment.
Thank you so much. Hi, I'm MK Fletcher. I am the Safety and Health Specialist with the AFL-CIO. We're a federation of 60 unions. We represent more than 12.5 million working people, including millions of healthcare workers, those who work in healthcare settings, and those who have and will be patients. We are happy that the guidelines are being updated as we have learned so much more about how to control infectious diseases since 2007 and from the world's experience with airborne COVID-19. We know that in order to protect workers and control the spread in healthcare facilities, adequate ventilation and quality respirators must be used. There are numerous lab studies that show the effectiveness of respiratory protection to protect against airborne pathogens over surgical masks. The evidence review needs to be expanded to include these laboratory studies, so it's presenting the full body of evidence on respirators, masks, and other PPE. Also, the guidelines must be grounded in transmission and exposure control. There is a lot of infection expertise around the table, but this must include exposure control expertise, including aerosol scientists, ventilation experts, respiratory protection experts, and industrial hygienists. Industrial hygienists are those who understand workplaces and how to combine hazard and control information into worker protections. It's unclear how these experts have been involved or if they've been involved. This is how to make sure that those impacted by this guidance, healthcare workers and patients, are properly protected from exposure to infectious agents. The impact of this guidance and the changes that is made here is significant. We watched the horror in hospitals with COVID, and now things have somewhat improved with COVID, but from the limited data we currently have, it's still circulating and causing at least 30 fatalities among nursing home workers last month and many more hospital-acquired infections. We must apply the lesson learned to all pathogens. We wish we had been here earlier in the process, but the process is not as transparent as it should be. Even just today, I've heard the group discuss how to word things with clarity for all healthcare workers and the public, yet the language hasn't been reviewed by those individuals or those who have expertise in that type of communication to ensure clarity. We hope to work with you all to ensure that this guidance is strong and protects everyone in healthcare settings. And if there are other ways to participate, we would love to know, to be involved, and to help ensure that all areas of expertise are at the table. And thank you so much.
On to the next comment. Thank you.
Lara Jirmanus, it is your turn for public comment.
Hello, and thank you so much for this opportunity. My name is Lara Jirmanus. I am a practicing primary care physician who has spent my career working with underserved populations and communities of color. I today testify on behalf of the Massachusetts Coalition for Health Equity, an organization of over 400 medical providers, disabled patients, and community advocates in Massachusetts. I am also on faculty at the Harvard Medical School and also affiliated with the FXB Center for Public Health at the Harvard T.H. Chan School of Public Health. I have no conflicts of interest to disclose, and I do not speak on behalf of my academic institution. I am grateful that the CDC is discussing the issue of airborne transmission, and I agree with all of the critiques that have been put forth here today. I'm also concerned that large hospitals may have a conflict of interest in the implementation of infection control measures because of the cost of masks, universal screening, testing, and other issues. I'm deeply concerned with the lack of input in this process, and the public comment portion of the agenda has occurred after many of these votes have occurred. I should also note that I am a member of the People's CDC, and we remain committed to working together with the CDC to ensure an equitable and comprehensive response to end the COVID-19 pandemic, because it unfortunately has not ended. We need input from occupational health experts, industrial hygienists, and aerosol scientists whose expertise would be very helpful in this area. We need more input from impacted communities, workers and unions, disabled and immunocompromised patients, and health workers. This process was essentially kept secret, and even so, you can see the broad range of people from experience and as well as geographies and professions that took their time from their schedules to unanimously call for increased protection today for healthcare workers and patients in healthcare facilities using N95 respirators, papers, and other respirators. I'm also concerned by undue influence from large hospitals, some of whose administrators sit on these communities. With hospitals in an unprecedented budget crisis and losing money canceling procedures due to COVID-19 infections being detected in patients, along with the fact that liability waivers are no longer in effect. So patients who are infected with COVID-19 may now more easily seek legal recourse if and when they are infected with COVID-19 during medical care, means that hospitals may be advocating against COVID-19 infection control measures because it benefits them financially. This is a potential conflict of interest which should be investigated, and I would argue that employees of large hospitals should not sit on this committee. I am lastly troubled by the suggestion that we have reached a point of population immunity where we do not have to try and prevent COVID. I urge you to implement a more broad process for public comment and maximize aerosol protections, including the use of N95 respirators and universal screening testing in healthcare facilities to prevent COVID infections. Thank you.
Thank you. Next comment.
Rita Valenti, it is your turn for public comment.
Yes, thank you. My name is Rita Valenti. I live in Clarkston, Georgia. Can you hear me? Yeah. I'm a retired registered nurse from a large hospital in Atlanta. I'm a former Georgia state legislator, and I'm here today because of my decades as a bedside and triage nurse, a concerned and deeply involved community advocate, and as a volunteer with the People's CDC. I want to thank you for organizing this hearing and listening to our testimonies, specifically regarding the transmission of SARS-CoV-2. I have a few brief points to make. One, COVID is airborne and can be transmitted by patients and healthcare workers who are asymptomatic. Healthcare facilities must require universal masking of well-fitting masks for everyone in the facility, with N95 as the baseline. It is true on the masking question that while a surgical mask may be effective in blocking splashes and large particle droplets, it does not filter or block very small particles in the air that may be transmitted by coughs, sneezes, and talking. Surgical masks do not provide a complete protection from germs or viruses and other contaminants because of the loose fit between the surface of the mask and your face. Instead of recommending surgical masks as a baseline, HICPAC should recommend the use of N95s along with better implementation of N95 protocols. N95 mask fitting should be required for healthcare workers. CDC and HICPAC should consider the inclusion of expertise of aerosol scientists and occupational hygienists in reviewing studies before making recommendations and prior to voting on those recommendations. It's also important to recognize that the optimal way to prevent transmission of microorganisms such as viruses is to use a combination of interventions from across the hierarchy of controls, not just PPE alone. Patients being admitted for outpatient procedures or inpatient admissions must be tested for COVID-19. Hospitals should continue to report all COVID-19 positive tests to the CDC, as well as percentage of positivity. Patients who test positive for COVID-19 should be admitted into isolation and placed in negative pressure rooms. Basement level standards of a crisis standards approach that leaves determinations of protocols for respiratory transmission of pathogens up to employers is unacceptable and can undermine both the health and safety of patients and healthcare workers, and by extension, the community. Though the CDC does not have regulatory power, strong universal recommendations from the CDC are needed. More transparency and ease of accessing deliberations of HICPAC and CDC would help to reestablish badly needed trust with communities that are unequally impacted and concerned communities, as well as healthcare workers. Thank you for your time today.
Thank you. We can move on to the next comment.
Roy McAllister, it is your turn for public comment.
Can you hear me? Hello, can everyone hear me?
Yes.
Okay. Good afternoon. My name is Roy McAllister. I'm the Director of Occupational Safety and Health Office of the United Food and Commercial Workers. CDC and HICPAC should engage with stakeholders more effectively, including direct care healthcare workers, their unions, patients, and community members, to provide them with the ability to review and provide essential input into guidance updates. The United Food and Commercial Workers represents 1.3 million members in various industries from healthcare, food processing, meat packing, retail, food and non-food, cannabis, chemical, and distillers. Our membership is as diverse as the industries we represent. Because of that demographic, we are important stakeholders in maintaining the health and safety interests of our members and the community at large. Part of our diverse union membership includes tens of thousands of healthcare workers. The COVID-19 pandemic brought forth the importance of ensuring the safety of our healthcare workers and illustrated the stressful conditions under which they work and how vulnerable they are to the risk of being exposed to the everyday hazards of infectious diseases. CDC and HICPAC have, through their practices, processes, and organizational composition, excluded UFCW healthcare workers from having the ability to review and provide valuable, essential, and direct impact on the guidelines under which they are governed. Those practices are ineffective and counterproductive to engaging the union, the community, and the frontline healthcare workers in the development of updates that will keep everyone safe. The lack of transparency has further eroded the foundation of enabling the stakeholders to have an opportunity to be proactive instead of reactive in matters of health and safety as it relates to keeping everyone safe. To rectify those issues, there needs to be representation from the unions who represent healthcare workers, such as the UFCW, on the committees upon which HICPAC and CDC serve. The committee should also provide a liaison between the healthcare community and HICPAC and the CDC. This would give them a better understanding of what is needed to make sure the processes and procedures that are in place will protect healthcare workers when they are confronted with the next public health crisis. Thank you for your time and thank you for the opportunity to speak today.
Darius Sivan, it is now your turn for public comment.
Hi, can you hear me?
Yes, we can hear.
I'm Dr. Darius Sivan, an industrial hygienist with the United Auto Workers. Although we don't have a major healthcare presence, we do represent about 5,000 workers in the healthcare sector. And we would like to very much associate ourselves with many of the concerns expressed today, particularly it took far too long to recognize that SARS-CoV-2 was transmitted by the airborne route, and it took far too long to get the proper recommendations for ventilation and personal protective equipment such as N95 respirators or even elastomeric respirators in place. We are terribly concerned that the way this body is going today is a major step backwards and does not provide adequate protection for healthcare workers from an airborne transmitted disease. We would like to see, as many other people, we do believe that the science supports N95s and other NIOSH approved respirators over surgical masks and ventilation for the purpose of capturing pathogenic aerosols, and we are terribly concerned that this body is not going in the correct direction, and we would like to see the recommendations strengthened. Thank you very much for the opportunity to present these comments.
Thank you. We can move on to the next comment.
Barry Hunt, it is now your turn for public comment.
Brianna, can you say that name one more time?
Barry Hunt, it is now your turn for public comment.
Hi, can you hear me?
Yes, we can hear you clearly.
Wonderful. So I'm Barry Hunt, and I'm coming to you from Canada today. I've been involved with healthcare for about 40 years, with CSA National Standards for Healthcare for about 30 years, and with ISO International Standards for Health for about 20 years now. I'm the president of the Canadian Association of PPE Manufacturers, the CEO of a private company, Prescient, that develops engineered infection prevention, including reusable respirators and specialized materials like nanofiber and plant-based filtration materials for respirators, and involved with the Coalition for Healthcare Acquired Infection Reduction, with Hospital Engineering Society in Canada, with HICPAC, SHE, APIC, et cetera, and a dozen other organizations. I'm really heartened to see that there's almost universal support from the public comments for universal use of N95s. So that's great. I'm glad to see that Novel Air Precautions recommends N95s and your extended air precautions. I don't like the fact that we have routine air precautions only recommending medical and surgical face masks. And they are half measures, and half measures will never work. I think we've seen that. And eventually we have to transition away from surgical masks to a minimum N95. So I'm currently involved with CSA National Standard update for the selection, care, and use of respirators. And we're really wrestling with the fact that our current standard currently says if you follow our control banding, a minimum N95 is required for SARS-2. However, that is not universally happening in healthcare. And so it needs to be rewritten in a format where people will clearly see that would be required. One of the problems, though, one of the reasons people don't want to wear N95s is they're uncomfortable, they're too hard to breathe through, they're too hot, et cetera, et cetera. And that is a fundamental problem. And if we look at how we got to respirators, they came from the mining industry initially, and they were designed to prevent rock dust, not bioaerosols. We have 2 layers of filtration material in each respirator when 1 layer would do. We could make every respirator used for healthcare twice as easy to breathe through by using a single layer. It's exactly the same construction that we have for medical masks, but of course, medical masks aren't sealed. So I'm firmly in favor of using comfortable, easy to breathe through respirators for all use. And I would hope that the committee would take that into consideration and work with their partners at NIOSH to move in that direction as well. Thank you for your time.
Thank you, Barry. Move on to public comment.
Greta Fox, it is now your turn for public comment.
Hello, can you hear me?
We can hear you clearly, Greta.
And I am a nurse practitioner with a degree in family and community health and a founding member of the World Health Network. My concern is that this committee is making a grave error in lumping masks, gowns, and gloves together. Masks and respirators are respiratory protection against airborne pathogens. In combination with gowns and gloves, they are barrier protections against body fluid contact. This is basic. According to the World Health Organization, COVID is still a threat. It is a preventable airborne infection and leading cause of death, which is killing a person every 4 minutes worldwide. According to Fauci, there is no herd immunity with a continually mutating virus. The arsenal of effective treatments is shrinking, as is access to vaccines, tests, and treatments. Any infection poses a risk of disabling long COVID, and it goes up with repeated infections. I am speaking up for patients. Any individual anywhere in the facility could be immune compromised or live with someone who is, or simply prefer not to become infected with a biohazard level 3 pathogen, which is proven to damage the immune and vascular systems and other organs and systems as well. One-way masking is insufficient protection and is impossible for patients who are disabled, are unconscious, or babies or children to choose to protect themselves. And limiting protection to specific areas of the hospital fails to protect people in waiting rooms, elevators, restrooms, etc. We've been advocating for N95s for healthcare workers for reasons already presented. Now we have to beg healthcare workers to at least wear anything, with no guarantee that this request for accommodation will be granted. Patients are putting off necessary healthcare because they are afraid of being harmed. We do not consent to risking forced infection, disability, and death in order to access healthcare, nor should we have to. Thank you very much for the opportunity to comment.
Are there any liaisons or ex officios online that would like to report out? Please raise your hand. Paul Conway.
Thank you very much. Hopefully you can hear me.
Hear you good.
Okay, thank you. A couple of different items. Just as a heads up, on March 9th, American Association of Kidney Patients held a roundtable on COVID-19 concerns for immunocompromised transplant patients. During our National Patient Consumer Roundtable, we featured Dr. Jeff Silverzweig of ASN, the American Society of Nephrology, who's the co-chair for the COVID-19 response team. We put that roundtable recording out to 22,000 high compromise kidney patients. In April, we issued a joint statement with the American Society of Transplant Surgeons and the American Society of Transplantation on joint principles in regard to increasing organ transplantation and making certain that inequities in the system for minority populations were taken into account and high-risk populations. On May 10th, we issued a statement regarding the public health emergency entitled "Don't Forget Kidney Patients, Their Vulnerabilities Remain." And in that, we cited the ongoing need for the HHS Office of Civil Rights to monitor hospitals and healthcare settings to make certain that high-risk kidney patients, including dialysis patients, were not put at risk again as they were during the pandemic and denied access to life-saving services. I would like to add that we shared that with the U.S. Congressional Kidney Caucus, the White House, and HHS Secretary Becerra. And after today's presentation, we have ongoing concerns for both kidney patients and their families and safety in a hospital setting or any other healthcare setting. We're looking forward to working with the CDC on several different things, including disseminating the announcement of kidney disease surveillance systems that the CDC will be bringing forward, and also our ongoing work with keeping dialysis safe, that initiative, which we were one of the founding partners in. And just as a final comment, I will give this comment, that I do think that the process here should be re-examined by CDC to make certain that public comment precedes the vote, because as a immunosuppressed kidney patient, and for the American Association of Kidney Patient members who have been listening today, it is nonsensical to change the standards for protection for immunosuppressed patients, whether they are organ transplant recipients or others, without having a clear insight into the mortality data and the risk that we've just gone through for 3 years. And we have an ongoing and serious concern about the lack of clear communications that are coming out of federal agencies. And unfortunately, I don't like to say this publicly, including the CDC. I have a role today as a liaison but the representative voice of patients and caregivers needs to be incorporated throughout the process, not on the day of a meeting. And I will make certain that my comments for the record reflect the reports that I talked about here and also my comments today. So thank you.
Thank you, Paul, for your comments or for your report.